All right, Dr. Patel, we're live. Please take it away.
Thank you for joining this webinar today on the orthopedic considerations of working in the cardiac catheterization lab. We hope this webinar will be both informative and helpful. Today's webinar is part of the wellness series organized by SCAI's Physician Wellness Committee. Interventional cardiology is expanding its footprint in healthcare and therapy. Myriads of demands include, of course, our work in the cardiac catheterization lab, and the field is increasingly becoming well aware of the consequences of that work and the cost to the physicians and the staff. Radiation exposure is usually the central focus, including by regulatory commissions, oversight, and quality committees. Less emphasized is the physical and orthopedic cost with a much higher injury rate, while it can be just as disabling. This is an expansive issue, so today we'll focus on the specific aspects that we think will be most helpful for the operators. I'm Islam Abadeh, an IC and co-chair of the SCAI Wellness Committee. My co-moderator is Dr. Bhaski Patel, and we are pleased to have an outstanding panel of speakers, each a specialist in the area and with a wealth of experience and expertise focusing on this area of orthopedic injury and the pain and how to best mitigate it. Leading the panel discussion will be Dr. Alison DuPont, chair of the Physician Wellness Committee. We'll have a more interactive approach today and encourage the participants to pose questions in the chat box, especially in the sessions with Drs. Harverton and Dr. Kunkel. I want to also thank the SCAI education team for organizing this activity, especially Kristen Perry and Laura Porter. We want to begin by introducing my good friend and colleague, Dr. Ahmed Athar, Chief of the Cardiology Section at Loma Linda VA, and who will be speaking on the leader's role in setting up a supportive cath lab environment, equipment setup, protections, and scheduling. Thank you again.
Thank you, Islam, for the kind introduction. And thank you to the SCAI team for having me, for the invite. Should be able to see my slides here. And as Dr. Abdai said, there's a few different topics that I've been asked to go over. So we'll get right into it. I don't have any disclosures. So let's talk about a goals of care discussion, sort of where we're at with our own healthcare in the cath lab as operators. As part of the assignment that I had, it's the perspective of the leader. So it's important to try to be the leader that your team needs, and you need to have your finger on the pulse. You also need to know what the risks are, so you have to be informed and know the data, as a lot of folks don't have more of the advanced protection systems. So you have to be able to build a case to your administration, and to know the data is to understand your approach to that. You have to embrace the responsibility. I mean, you have a whole team of people that really are that you have to care for and care about, and it has to be genuine. So you have to embrace that responsibility and have regular check-ins. One of the most memorable moments of my career here at the VA was on day one after I spent a couple years in private practice. Day one, showing up with the cath lab, getting a huddle together of all the staff and telling them I love them, I care about them, and that I'm on their team, and I want their success to be my success. You have to lead by example. So that means taking care of your own wellness and then asking about others. And then you have to be prepared to relentlessly advocate for the team and for all the things that you need to have a successful and healthy team. So Dr. Abadaya and DuPont and Hermiller, doctors, I should say, had published this really impactful survey that was a follow-up to a survey 10 years prior. And so in this survey of nearly 300 interventionalists or staff, we saw what the caseloads were. And so these caseloads that you see here, this may seem high for those in Southern California, but having practiced in the South, this is about par for the median. And so we see that in our operators, about 2/3 are experiencing musculoskeletal pain, 60% reported orthopedic injuries. I saw cataracts. And 1 in 5 reported having decreased time in the cath lab due to orthopedic injury. A shocking 82% would retire later if the injuries were prevented or better managed. So this is really changing, the workforce, and unfortunately handicapping what we're able to offer our patients and to build our teams. It's important to understand the risk factors for injury from this survey, which highlighted this very well. It's a very well done survey. We know that the higher the workload by quintile, the more injury people had. And more time means more pain. So those who've been in the field for more than 60 years as operators had a 77% rate of injury. And it's not just interventional cardiologists, surgeons, including CT surgery colleagues and spine surgery colleagues have published their own surveys. And I won't go through all this in the interest of time, but this is important to know this information because at times you can kind of have a team approach with the administration and say, this is a problem that's affecting multiple operators who do really important work for the facility. And having a team-based approach to approaching the administration is helpful. So I showed you some data. Now I'll show you an data point. So 30-year-old fellow, second year, didn't ask for 5 months of the cath lab in his first year, but was assigned that. And another 3 or 4 months at least of cath and EP in the second year. Starts having severe back pain and spasms and limits their ability to work and walk, and had a prior history of lumbar back pain, probably related to the 8 or 9 times they had to move through college and medical school and residency and fellowship. It gets to the point where can't walk and the back is contorted to the side. This is the MRI. This is me when I was 30 years old, halfway through my general cardiology fellowship. I had to be in physical therapy, traction 3 times a week at the local physical therapy center to get back on my feet. And so identifying these injuries early on is important, but this can happen to anybody, even if you think you're in great health. Let's talk about some options to optimize the workflow or solutions to shed lead. So if you can't get the higher ticket items on your in your cath lab, we have appropriate apron sizing. It's important to get measured. You can have supported mats in here. This is an example of the WOW belt, which I'm not endorsing any particular product, but it's a lumbar support belt. Understanding ergonomics, which we're going to have a wonderful talk on later. And again, the best investment is yourself. Spend that time getting your core strength up. We'll have a discussion a little bit with Dr. Trong about left radial. You can use assist devices or set up on the left side for ergonomics. Lead aprons, we know they're limited. There's incomplete coverage, and you are going to get axial load in the spine, the hips, the knees with this, as some of these can weigh 20 plus pounds. So we have different solutions to shed lead, and we'll go over a few of these. And I put this in alphabetical order to not have any bias for our talk here. All of these have been studied and report pretty good radiation exposure. There's pros and cons to each, and you have to explore and choose what best fits your needs. And consider pairing one of these systems with a live monitoring system if you can. So quickly we'll go through Egg Nest. So you have a protective dome shield. It's adjustable, it blocks radiation above and below the sides, reducing scatter. And there's a few different varieties of these. Protego, this is a modular glass panel and flexible shields, and reduces scatter through high risk areas. This was studied to show a pretty significant reduction in a lot of cases by, I believe, Dave Reisig. So this is kind of a workflow. This is what an example would be like here. And reaction, this attaches a C-arm, kind of cool. I've not seen this even in our tech displays, but it's modular. So you have this attached to the C-arm, and it comes down, up and down, and it goes with the detector of the ion. And so this is what this would look like, and it will go along with the angle. So you shouldn't limit your angles there. The Rampart is what we have, combination of modular shields and flexible skirt. So you have your ceiling and boom mounted Guardian, which is one model, or the rolling stand mounted Defender. And you can add on the bunker and shadow tableside shielding. So this is the Guardian. This is boom or ceiling mounted. You can have that set up for coronary or any of these other workflows, peripheral, for example. This is the Defender, which is what we have. And that can be wheeled in and out. You can use one for multiple labs if you need. And this adds a lot of shielding to the side. The Zero Grav, that's my cue to speed it up. The Zero Grav is just going to be around the operator. This is an example in our lab. And so this is our setup here. We have live monitoring. And so really quickly, in terms of hustle and workflow of scheduling, remember that fatigue and injury begets more fatigue and injury. So try to rotate your operators and staff. It's probably better than having a long block of 5 days in a row, 2 weeks in a row. Try to rotate folks in and out if you can. Encourage stretching and wellness breaks, which we'll go over, and early recognition is important. Lastly, the culture. So what does your culture look like? What are your barriers? What are the competing interests? You have a tug of war between administration and costs, and then the operators. And so you want a team approach here. Work with your other service lines. lead by example and make the case that there's added value in prioritizing the operator's staff wellness and reducing attrition and burnout. So I'll leave you with this: shoot your shot. You miss the ones you don't take. So build your case and be persistent. And then lastly, this is going to be a segue into the next talk. Islam, is the pregnancy talk the next one?
Yes.
It is.
Do we have 30 seconds to go over this real quick? If that's okay. So as a leader, you're in a situation, you have a newly graduated interventional attending. She joins the practice. Within 4 months, she's expecting a baby, which is fantastic. So what do, right? So we always talk about men on a panel being a manel, right? So we haven't been in this position to be a first year attending and then have to be facing these challenges of balancing work volume, accessibility to experience versus protection for yourself and the fetus. So Dr. Harberton will talk a little bit about the innovative program that we put together for her first year. And I'll have to just say that in her first year, she had the highest operator volume by choice compared to her colleagues, and did so in a safe fashion. So I'm happy about that. Thanks. Sorry for going over.
Yeah, I definitely couldn't have done it without support of my amazing colleagues. But are we going to go on to the pregnancy part?
Dr. Bosky?
Yes.
Go ahead.
Okay.
So the next
Yes.
speakers will be Doctors Gonkel and Dr. Harberton. It'll be more of a discussion venue where we will be able to ask questions. Dr. Patel will be asking questions, and we also will take questions from the panel. So if anybody has any pressing questions, please feel free to put them in the chat box. We'll be happy to address them to these speakers. And I believe Dr. Gonkel has a couple of slides to go over first.
Thank you. Dr. Ashar, thank you for the presentation. Next up, we have Dr. Golda Havartan, who is at Loma Linda, interventional cardiologist at Loma Linda University in California. And we have Dr. Catherine Kunkel, who's at the Piedmont Healthcare System in Atlanta, over pregnancy in the cath lab, which I think is been gaining some traction in the last few years and is very relevant to you guys.
Did you say Dr. Kunkel had some slides, or?
Yeah, I can show.
Okay.
It's so I don't really have any datas or organized slides, but well, I guess I do have a couple slides. I was just really curious about my own data during my pregnancy. I think we all kind of, there are a bunch of papers out there that go over operators, but I've never seen anything broken down to like, okay, this is an individual operator. How many cases did she do? How many PCIs did she do? What was her radiation exposure? So I was just really curious what my own numbers would show. And so I found a couple interesting things. So this is my personal data. I compared, so the blue is what I said my baseline is. So it's my pregnancy. I found out I was pregnant at the very end of December, and my daughter was born in mid-August. So we say my pregnancy data is January through August of 25. And so I use 24 as kind of like what was my historical baseline. And so a couple interesting things that I found when I looked through my own data. First, I actually did more cases and PCIs while I was pregnant in the same time period compared to the previous year. And I think it was a really busy time in our cath lab. One of my partners retired. But despite having higher productivity and case volume, my RVUs were also higher during my pregnancy than the baseline year. My radiation exposure was a lot less. And so I made a couple changes. I thought I was actually a pretty radiation savvy person before I got pregnant, and I made a couple changes to my general practice. So despite doing considerably more cases, my overall thyroid dosimeter DDE dose was a lot lower, almost half as much. And so the big changes I made were when I started trying and I knew I was hopefully going to get pregnant, I had my lab replace all of the lead skirts on the cath lab tables. We had all these like torn lead skirts that were partly falling off. So we got all new lead skirts for the lab. I started using double rad pads for every patient who was over 100 kilos. And I started doing everything on fluoro minus. And so I started every single case on fluoro minus, and I think it made a really big difference. When you look at my fetal, which is in the yellow, my fetal exposure, the first thing is this was not easy data to get. I had to like find a random guy named Chad at like the radiation badge processing, and it takes 2 months to process the data. So I would like have a reminder on my calendar, like email Chad to get your data every month. And it was the data for 2 months behind. And you'll see my data is really great until June, right? I had like 0 to 2 millirems on the fetal badge, which was spectacular. And so like what happened in June? And that was when I switched leads. So just to give you a sense, these are the 3 leads that exist in my life. My normal lead is 15 pounds. It's a 2-piece. I've always worn sleeves. I think all women should wear sleeves if you don't, just as a breast cancer prevention. And that's my baseline lead. When I had pre-ordered this like belly cover band for this other older set of lead that I had, it's a little heavier, but this gave me excellent protection. It was not too onerous to wear. But when I got too big for it, I finally switched into this 1-piece that was, it's actually a little lighter when you weigh it, but it feels so heavy because it's a 1-piece riding on your shoulder. And it was a 0.35 all around, which made it really heavy, but actually gave me half as much protection in the front than the previous lead. And so I really think switching to this 1-piece lead is what led to my increased fetal exposures. And it was about 20 milligram a month for the last 2 months. And I think that also gave me this. So I also have my herniated disc MRI. So you can see my L5, S1. I learned this. I'd never read these before. Your discs are supposed to be white and the black one is bad. And so that's what happened to me from the maternity lead. So at the beginning of my pregnancy, it was not at all on my radar to think about orthopedic health. I was only thinking about radiation safety and protecting the baby. And clearly my thinking around that has changed now.
Yeah. So I can shift
So
gears
Dr.
a little
Huckle, thank
bit.
you for sharing that. Sorry.
Sorry. Go ahead.
I just actually wanted to follow up with a few questions first, if that's okay, Dr. Vartan. So, you mentioned that one of the things you changed, Dr. Kunkel, was getting your cath lab to change out all the lead skirts. Tying in with the last case, how did you initiate that conversation? How is it with, I know cost is always a concern for administration, and some of this is trying to find the right colleagues and the right support. How were you able to navigate that conversation?
I was like ready to go to war. And I went to the cath lab, my cath lab director, my boss, and I said, hey, I'm going to start trying to get pregnant and our radiation skirts are torn. Can we get new ones? And they were installed the next week. So I think for me, and this is a super personal decision, but like transparency around this stuff, I think can really help you. And I understand some people want to be private with their own health journeys and you have to do what feels right for you. But for me, it's kind of easiest to wear it on my sleeve. And I was like, hey, I'm trying to get pregnant. I don't want to have bad shielding. And so that I think really helped the discussion.
Okay, like out there. And then, another question I had about this, you mentioned the lead that you wore in the middle portion of this pregnancy with the extra did you have to work with any kind of therapist? Did you do any extra stretching to kind of, obviously independent of the lead you?
Oh, sorry. Are you?
Got extra weight, right? With being pregnant. Did you have to do any kind of adjustment to your regimen to kind of work around that?
I probably should have. I think one of my big lessons learned from my pregnancy was that I did not do a good job of taking care of my orthopedic health at all. I was also working like insane hours. I was putting up like 100, 120 cases a month at this point in time, at the end of my pregnancy, just because of what our lab needed. And I would definitely do things differently next time around.
Thank you. Dr. Havartan, we'll jump into your segue here.
So I don't have any slides, but I can talk a little bit about kind of what my group did and kind of what I found really helpful. So I do definitely agree with Dr. Kunkel. I also think that, you know, being transparent is really helpful. I actually ended up telling Dr. Athar that I was pregnant about 2 days after my pregnancy test, just because it, you know, I do kind of, I'm fairly transparent anyways, but it also helps with kind of making the decisions and kind of organizing things, you know, amongst your group. What we did at the VA that I thought was really, really helpful is um, we kind of rearranged the schedule so that in the first trimester, I actually was not physically in the radiation. I actually sat in the back room, and we would whoever else was on in the case, we would actually, you know, I would do the measurements of the IVUS, or we would discuss things about the case, and it was almost like they were, you know, I would still kind of make the bigger decisions as far as like, okay, you know, do we send this? Do we send this for cabbage? Do we do FFR? You know, whatever. And I think that that was really helpful because for the entire first trimester, where, you know, really the fetus is kind of the most radiosensitive at that time, I was able to you know, completely shield from radiation. I did do some cases within into my second trimester. I did start doing cases like actually in radiation again, and we did have Rampart, and so that definitely reduces the radiation a lot. But I was also doing occasional cases at the university hospital with. And over there, I also wore the belly band along with, you know, a full set of lead. So that was kind of my experience. I think that, you know, the biggest thing is for me was having a very supportive group.
I can just add, thank you, Dr. Hartman.
Yeah.
You know, in our practice, it's an academic practice. We have trainees, so we have, you know,
Right.
Junior fellows, senior fellows, interventional fellows. So she would be in the lab supervising these fellows from the control room, like any academic practice would. And then when there was a need for interventional attending during the first trimester, one of us would be scheduled to be available as backup to go in, which she still would get credit for these procedures that she's supervising, but just she wouldn't need to have her hands on, you know, or, you know, be table side to protect herself and her fetus. So with that flexibility, and then again, it was more of what she wanted. You know, you got to listen to what, you know, your colleagues want from a cath lab director standpoint, but nobody knows what's best for the baby besides, you know, mom, right? So who am I to tell her what to do?
Right.
So
Yeah, thank you for that. That sounds like exactly the kind of environment people should be training in.
Right.
Sorry, Islam, you were saying?
So this question is for both you and Dr. Kunkel. Obviously, as you mentioned earlier, in Europe, there's a considerably different approach to pregnant people. I know that in Norway, just like in Italy, for example, you can't be pregnant in the cath lab. In the US, that is thankfully not the case. So the question then is, have you noticed any change, or did you have to make any change in your career work, in your ability to scrub in, to do procedures, and to do types of procedures that you want? Or did you have to mitigate that during your pregnancy, before or after, that sort of a thing?
Yeah, I was incredibly fortunate to have minimal symptoms in terms of like nausea, vomiting. That's actually what I was mostly worried about. And so I did not significantly, other than my radiation practice, I'm in private practice. I don't have fellows. There's no one I can supervise. It's me and a tech. So no, my case volume actually was about 20 to 30% higher than the preceding year. And most of the work that we do at Piedmont Atlanta is surgical turndowns, CTOs, high complexity cases. And so for me, that's why it was so important as the pregnancy went on to review my data every month. You know, and I think the other thing, that belly band idea, I had mine like purchased and sitting on the shelf in the cath educators department before like months. Like when I got married, I was like, I will someday probably have a child. Let's buy this for me so that one day it's sitting there. And so truly, I took a pregnancy test between cases and called my husband from the bathroom and then went and got my pregnancy shield. So I think I was very ready for that, but and I was lucky. I think toward the very end of my third trimester, it was a little bit physically harder to do cases that were longer than say 2 hours, but those are obviously the minority of cases. So yeah, no, I pushed pretty hard.
Yeah, I also, when I first onboarded at the VA, I got measured for the belly band, kind of had it already ready. And they actually, they put a few extra like inches into my lead because I told them I might get pregnant at some point. And so my lead was kind of ready for me already. And then I did, I did find that in the first trimester, I had a lot of nausea and a lot of fatigue. I was very, the first trimester was probably the most symptomatic for me. And so but that was kind of when we had this system of having kind of a backup interventional attending kind of already built in at that point by the time I, became symptomatic. I will say the only thing that I found that I was unable to do was by the time I hit my third trimester, the belly was quite in the way, and we tried to go left radial on a case, and I was miserable, reaching over the table and everything. And so my threshold for, if this is a possible left radial or going femoral, even though I'm almost always a radialist, my threshold was slightly lower in the very end of my pregnancy.
Yeah, I also traded all of my third trimester calls away. Once I was like toward the end of my first trimester and feeling pretty good, I was like, okay, let's load it up. So I did a lot of call at the end of my first trimester, the beginning of my second trimester. I just traded it all back. And so it worked out really nicely. Kind of the last 2 months of my pregnancy, I didn't have any calls because I had traded them, and I would strongly recommend if you have enough people in your group that you can do that. It's already hard enough to sleep in your third trimester.
Yep.
Adding semi-call to that is a challenge.
So I thank both of you, Dr. Harvett and Dr. Kunkel. For the sake of time, we'll move on, and we definitely can circle around to these conversations during the panel discussion. But I appreciate your presence here. So up next will be my good friend and colleague, Dr. Trong. I've worked with him for the last few years, and it's been my privilege. Not all procedures are the same in the lab, and considerations change from one approach to another. So we're really happy to have him be able to speak on that.
Right. So thanks everybody for having me here. So we'll talk about procedure-specific ergonomics, and it's not just about the lead. So I don't have any conflict of interest. So we all heard about the orthopedic injuries here, so I won't dwell on it for too long. One of the things that we kind of ignore a lot of times are the staff. So one of the study actually showed that the staff have higher rates of musculoskeletal pain despite of being younger age. The reason is that they, a lot of the doctors, we rotate through clinics and other things while the staff are working in the cath lab day after day. So especially if you have a cath lab manager, make sure to rotate the staff so that they're not doing the same task over and over again. And then the staff also have to transport patients. And then, sometimes they do manual pressure. So whenever we have a manual pressure, I always hold and tell the staff to go and take the lead off first and then come back and hold the rest rather than having them stay there with their lead on and hold. So where's the pain? So this one study shows that people have a lot of cervical pain, lumbar pain, but basically all along the spine and the shoulders. So the general strategy to reduce the injuries If you have the ability to get a full radiation protection system, I think that's probably the best. The robotics were kind of in vogue for a while, and then it's still, I think it's very hard to do some of the complex procedure with the robots, but perhaps in the future we'll get there. If you have to use the lead, you already heard about the two-piece versus one, and then good ergonomics, and then regular rotation, especially for your staff. So this was this morning. So we have a full radiation protection system. I wasn't wearing lead. These are just splash glasses. They're not lead glasses like I used to. And this is just a regular hat. So I don't wear the lead hat anymore because you're getting a full protection, protection for your brain, for your eyes, without having to wear additional weight on you. I remember I actually used to get headaches when I wore the lead glasses and the lead hat. So, and the people has actually done some studies looking at the two-piece versus a one-piece, and it actually does show that you get more pain and fatigue much quicker with the one-piece versus a two-piece. So it's the same thing that we've heard from before. All right, so the ergonomics in general, good posture. You want to minimize bending, leaning, reaching. The neck needs to be straight. So this is actually very important when you have the room set up, especially for some procedures that's not the routine femoral or right radial. And then clear the floor space. Some people use those mat. I found them to actually make things worse than just having a clear floor space. All right, so here's our setup. Our tech here is quite a bit taller than me, but you can see that I have the bed raised up way up, so elbow height. And if you ever use the standing desk, it's also about the same height. When you do that, your posture is straight, so you don't have to bend down. So I find this is actually pretty common when I work with other folks in the lab. They tend to keep the table too low, and then they have to bend over. So left radio setup. Here, my colleagues, Dr. Lee, Nathan, we publish this on the SCAI website tips here. So we actually have the ability to bring the left arm over, so that's right next to the right femoral area. And the tricks to do that, I think, a couple of ways. Some people like to do the distal. I actually don't like to put the sheath and have the sheath go through that snuff box. But the way that I do is I put a long radio sheath, but you don't hub the thing. You leave a little bit out. That way you can hang it out over, because when you move your left arm over, the radio would be on the bottom, right? So, and then it would be very awkward for the patient to have the radio up. So it'll be a more natural position for them to lay down their hand like this. So when you do it this way and you tape it, you have access to the sheath and the patient's comfortable, and you have access to where you would if you were going right femoral. This works for a lot of patients, except for the one with the huge belly. Then you wouldn't get you would get to about here instead of all the way to this side. There's some people who like to put it to stand on the left side of the patient. If you do that, just make sure that you have the screen right in front of you so you don't turn your head. The other procedures that we sometimes do is if you're going to do some right carotid TAVR, some big right IJ like angiovac. Here we move the room around, so we will sacrifice time. If you have a carotid TAVR, it's going to take longer time, so we don't aim to schedule 4 or 5 of those a day. And so we have the screen over here so that the interventionist can look, and then we have another screen over here so the surgeon can look. Then we have the surgeon stationed here, does the cut downs hold the sheath, and we have a natural way to get the right carotid work. And here's our anesthesiologist and the ventilator over here. So just when you get the room set up, just make sure that you're not turning your head or leaning, and it's doable. And here's, if you have to do a left carotid or left IJ procedure, sometime the right carotid, for a particular case, we prefer to go right carotid, but if it doesn't work out well, then we have to go left carotid. And it's a little bit harder to set up, but again, it's definitely doable. And just make sure that the screens are straight ahead of you so you don't have turns. I found a lot of time that's the issue when you have to move the room around and people don't set up the screen, and then they're turning the head through the whole procedure. So that's not great. So here we have the interventionalist over here this time, and then the surgeon is standing over here to hold the sheath, and the anesthesiologist and the ventilator over here. So that's all I have to do the setup, but the main thing is basically to keep your posture, make sure the screen's right in front of you so you don't turn your head, and stand as straight as possible.
Thank you, Dr. Trong. Appreciate you going through this, and we'll move on then to Dr. Ruby. But before I do, I want to mention that Dr. Trong was kind enough to have drafted a very helpful quick document available on the registration page, and I encourage everybody to access it. It goes over his approach to radiation safety and orthopedic injury. So next is Dr. Manolo Rubio, and everything we talk about typically in cardiology, most things relate to either valvular disease or coronary intervention. But of course, a fairly sizable part of our community works on vascular and peripheral procedures, and we have one of the has made a name for himself in the Southern California area as one of the most highly productive and capable interventionalists. So I'm proud to call on Dr. Rubio to talk about that.
Thank you very much, Dr. Obudeya, which, by the way, is a privilege being surrounded by mentors turned to colleagues turned friends as well. So I can attest to everything they've said. I learned to be an interventionalist at Loma Linda VA cath lab, and with Dr. Obudeya as well, and the University Hospital across the street. Thank you very much. Can you guys see the screen? Okay. Very well. Thank you. Well, we've been talking about coronary work, structural work. Now we're going to jump a little bit on a different realm, which is the vascular world, the peripheral world, or endovascular, whatever you want to call it, which is, I want to say, it represents a different type of challenges for several reasons, which we are going to talk about here. This is my disclosures. Okay, so endovascular procedures, across all the endovascular procedures, we face, prolonged standing radiation protection load if you're using a lead or leadless like I use, awkward angulation, multiple simultaneous vascular access sites, which are sometimes not ergonomic, not comfortable to work with, repetitive device exchanges, long wires, need to be an octopus and try to manipulate your 300 centimeter wires so they don't fall. On top of that, holding a balloon. On top of that, holding your laser. On top of that, using a snare as well. You need to. We need to understand that the importance of procedure planning for the endovascular procedures. On top of that, you add the radiation exposure that adds an extra layer of danger or something you need to worry about. Now, for the purpose of this talk, I'm going to focus on a particular area of endovascular procedures, which is peripheral arterial disease, which is very common, and a subset of PAD, which is limb salvage. In my experience, I've encountered that limb salvage procedures are usually very long, very demanding, but physically, mentally, and they require multiple access to achieve a potentially successful outcome. Awkward C-arm table positions, steep angulations, again, a lot of radiation exposure, and you may need to use both hands to intervene though. And if you add on top of that, that you may be the last chance the patient has, because limb salvage is a very, very, very niche area of practice. Most of the times when you're doing limb salvage procedures, you get a lot of second opinions. So that adds an extra pressure on you. And sometimes when we have this pressure, this makes us sacrifice some things, and one of them is our body, right? And our posture, the time we're gonna be in the lab. You say, you know what, I have to get this done, no matter what. If I need to bend, I bend. If I need to be off the the radiation protection field, I'll do it. It's not advisable. I don't recommend it, but that's an extra layer of pressure you have. For instance, this patient you see here, PAD, CLI, CLTI is usually diffuse disease. It's not focal lesions, it's all diffuse. It takes time, a lot of time. And I want to point as well that it's not just the spine, because we focus a lot on the spine, the neck, or posture and all that. Think about it. To go through all of this, you need your hand, right? You need your hand, you need to spin a lot, you need to push a lot, exchange wires, you get hand strain, hand fatigue. And I will say it very honestly, after a long CLTI procedure, what's more tired in my body are my hands, my wrists, my knuckles, my hands, because of the effort you cause that. And some of the times, whether you're an antegrade access or open over or pedal access, if you only use your dominant hand, something you have to be in an awkward position. With your antegrade or on the foot, you have to be in an awkward position. So what I've found helpful is to train my non-dominant hand to be able to also intervene with that hand and avoid putting a lot of strain on my dominant hand. Once you think you're done with this probably 20, 30 centimeter occlusion, then you cannot stop there. You have to keep going down, because you're doing a limb salvage procedure, and that also causes strain. You have to zoom in, you have to mag in, you have to strain your eyes as well. You have to bend over to look at this small pedal arteries. Sometimes you have to hold the foot. If the patient is, I do most of my procedures with anesthesia, so to avoid the patient moving, so we can work on the small arteries. But sometimes the foot is bent, and the patient obviously cannot keep it straight. For you to take a radiation-friendly angiographic view, and you have to hold the foot. So you have to hold your hand steady there, work with the other hand, your wire, whatever you're trying to manipulate to those small arteries, and that keeps adding strain in your hands. Of course, you have your spine as well, your neck, that are also suffering, to be able to accomplish a good result there. So like I say, it's not just the spine. Hand strain is real, especially in complex small vessel interventions. Now, setup and workflow to reduce injury. So we think that injury prevention happens during the case. In terms of endovascular, especially PAD, limb salvage, what I found is that prevention starts before the first puncture, before the arteriotomy. What are you gonna do? What can you realistically accomplish? Okay, I'm gonna open these 3 CTOs, all of them. Wait a minute, your maximum contrast, allowable contrast dose is 150. Are you really gonna do all that? Why don't you go and treat whatever has a better chance of being recanalized or treated? Table height, like Dr. Tron was saying, patient positioning. Are you going to do dual access, single access, antegrade? How are you going to access the patient? That way you minimize the need to get access on a different kind of access on the go, that when the table is set up for another access and you have to bend over to reach the sheath on the other side. Use your long sheets, support catheters to reduce strain. Prep the devices, have everything ready, anticipate what's going to come next so that you can minimize device prepping, bending over. etc. There are some devices that address orthopedic injury. Dr. Athar, Dr. Trong spoke about them, so I'm not going to get deep into that. Now, very important to protect the operator during these long cases. Segment the cases. These are not easy cases. These are not short cases. So segment them. Take a break. When there's a balloon inflation, sit down on a chair, just go walk around, stretch yourself, stretch your calves, stretch your hands as well. Micro breaks or device prep. Don't stay still on the same position or holding the table, because your muscles are going to be stiff, and you're going to end up with a bad headache, hand cramps as well, which I see them very common when doing CTOs. Distribute tasks across your radiation technologies or cardiac technologies, whoever's helping you. If you don't trust them, train them. They can be very helpful. I know there's operators that want to do everything. It does not work so much or so well with endovascular, especially because we have very long type of equipment. Just train your team, have your same team, rely on them, plan your procedure, and very important, in my experience, train your non-dominant hand. Train to be ambidextrous. That way you can minimize being on awkward positions and putting a lot of strain in your hands, which sometimes we don't pay a lot of attention to those, but can get really fatigued. Orthopedic injury is a major occupational hazard in endovascular or vascular procedures, especially in peripheral arterial disease and limb salvage procedure. Most of the discomfort, I have to say, in my experience, is environmental and not technical. I mean, most of our orthopedic strain does not come from just crossing CTOs or doing pedal access. It comes from heavy lead, static posture, a room layout, radiation strategy. And that's good news, right? Because we can change those things. The environment can be engineered. Skill takes months or years to build. The setup can be fixed tomorrow, right? Technology and workflow changes can extend operator careers. And if you enjoy doing this type of procedures, the longer your career you have, the more of a benefit you can be for all of those patients. Thank you very much.
Thank you, Dr. Rubio, for an excellent conversation on this. As we've mentioned, it is very important since we're doing all these other techniques and procedures in the lab as well. In the interest of time, we are going to save any other questions you may have regarding that to the end, and I will move to the next section. So I'd like to introduce for the next talk, Dr. Lee Chui, who is an interventional cardiologist in Tucson, Arizona, and a friend of mine. I say this as if I have as much years of experience as Dr. Abudaya, but Kathy and I have known each other for a few years as fellows, and we are early career interventional attendings. And also Dr. Christian Wright, who is a PhD in nutritional biochemistry. They will be giving us a much needed talk on the physical therapy tools that we can use to augment all the talks we've had so far and what we can do to help our bodies.
All right, everyone can see the screen okay?
All right. Thanks, Bosky, for that introduction. All right, so as we've talked about during this session, we have several issues in the cath lab leading to physical injuries, which several elements that do accumulate over time, over years, over our careers, including wearing heavy lead aprons. Like a 15-pound lead apron can exert up to the 300-pound pressure on the intervertebral discs. And then we're basically not conscious of being in a prolonged awkward position, which is not ergonomic. Particularly, as we mentioned, a lot of spinal injuries as well. Next slide. The SCAI's 2023 survey showed that more than half of interventional cardiologists and cath lab staff have musculoskeletal pain and orthopedic injuries, and it does affect our careers. And about 20 to 30% of interventionalists do miss work or have to cut down the time in the cath lab due to these injuries. Predominantly, the injuries based on the survey and also the ErgoCath report, as was shown in the prior slide, seems to affect predominantly the lumbar and the cervical spine. Next.
Let's talk about this common lab posture. So you can see we have cervical extension, we have this extended, internally rotated shoulders to manipulate the catheter, and often this rounded, fatigued lower lumbar. Now, if we strip away all the distractions, we start to see the three big issues with this position. So we have the extended neck, which causes uneven loading of the posterior elements of C4 and C7, so increasing disc compression. This extended shoulders, or really protracted scapular and internal rotation, increases the impingement, humeral impingement, which causes inflaming and damaging of the rotator cuff muscles. And lastly, the area that causes the most widespread issue is this rounded lower lumbar region, or fatigue slump position. Now, in this position, because this, instead of distributing the weight of the lead around all evenly along the pelvis, the flexion point is right around the L3 to S1, which increases disc compression, sciatic compression, as well as increases the atrophy of the psoas and glute minimus, which ultimately decreases the overall strength of the posterior chain. So how can we correct these three different positions? Well, we first tuck the neck back, we retract and depress the scapular, and we align the posterior chain. But it's not just a matter of getting into this position, it's also a matter of maintaining that position every day through every case. And how do we do that? Well, we do that by increasing the strength and the endurance of the muscles that's supporting this position. Doing so will help us become a more stable and injury-free. So let's talk more about how do we build this lead-proof body. First, let's talk more about getting into this correct position, which will keep you stable and safe. That's their ultimate goal here, stable and safe. So first, tuck in the neck, making sure the head is aligned with the body. Roll your shoulders up and down, or retract and depress the scapular, making sure the scapular is in the lowest position. And lastly, align the lumbar and the pelvis with the trunk, standing straight and tall, making sure not to have any sort of posterior pelvic tilt, so this sort of slump fatigue position, or anterior tilt, giving sort of the sway back look. The weight is evenly distributed across the pelvis and supported by the glutes. This is crucial for keeping you stable and safe in the lab and in all the upcoming exercises. In fact, if you take anything away from this presentation, is get into this safe and stable position as long as possible and maintain as long as possible. So let's talk about strengthening. So first, let's start strengthening the neck by doing some cervical retractions, rotations, and tilts. Rotations and tilts. Now remember, when you do these, make sure that the scapular is retracted and depressed and the posterior chain is aligned before starting your 3 sets of 10 to 20 reps. Remember, we're going for both strength and endurance with these exercises. Moving on, now let's increase the scapular stability. First, let's talk about wall angels. So find a wall, put your head and glute flat against the wall, retract and depress your scapular, bring your arms back so that the forearms are in touch with the wall, and slide your forearms up and down, making sure you're maintaining that retraction of the scapula. Next up, let's do some banded scapular retractions, which really help maintain and stabilize that proper position. It's essentially a row, but you're really just moving forward and back the scapular. You're not pulling with the arms, you're pulling back and releasing from the scapular. Doing both exercises for 3 sets of 10 to 20 reps. Now let's stay in the shoulder area and strengthen the rotator cuff muscles by doing both external and internal rotations. As you can see here, I'm doing with a band, but you could also do with a dumbbell by lying on your side with a bench with a dumbbell. And remember to make sure to retract and depress the scapula to keep your shoulder safe throughout this entire motion. Moving on, we're going to go to shoulder rotations. Now, this is where you bring your humerus parallel to the floor, fix your elbow in place, and move your hand up and down. And lastly, we'll do some pull-off presses, which is the anti-rotation press, where you're pressing forward while resisting the inward pull of the band. Doing all exercises for 3 sets of 10 to 20 reps. Now let's work our way down and work on stabilizing and strengthening the posterior chain. Now this is crucial here about first and foremost getting into the proper position. Shoulders back, neck tucked, and chain aligned. Now when in this proper position, you're going to push your hips back, hinging at the hips, and then continue going forward until your breaking point, which is when the back begins to slump or you have that fatigue position. And just before that, push through with the hips and thrust forward. Rinse and repeat. Now this is takes some time to learn, so start out using body weight, but as you become more proficient with this motion, begin to add loads such as a kettlebell or dumbbell. Next up, let's move on to the unsung hero of your posterior chain, your glutes, by doing some banded side steps. So place a band just below the knees and walk side to side while maintaining a constant outward knee position, resisting the knee from caving in. Next up, let's do a glute bridge. So lying flat on the floor with your knees bent, feet flat. I want to make sure to rotate your pelvis and your lumbar into the floor, making sure your entire lower back is flat against the floor, removing that curvature. Now, once you do that and you maintain that position, squeeze the glutes to thrust your hips forward. Hold at the top, rinse and repeat for 3 sets of 10 to 20 reps. And lastly, let's strengthen and stabilize our core. First up, bird dogs. Get into a 4-point position, making sure that your neck and posterior chain are in line. And while maintaining this position, extend your arm and leg in alternating fashion, holding and squeezing at full extension. And lastly, dead bugs, which is done properly, is probably one of the best and safest core exercises you can do. Similar to a glute bridge, lying flat, feet flat, knees bent, rotate the pelvis and lumbar into the floor, really pressing your entire back into the floor. Now, while maintaining this position, this constant pressure into the floor, raise your arms and legs in alternating fashion, both for 3 sets of 10 to 20 reps. So as we know, orthopedic users are very common amongst interventionalists due to poor positioning and these long hours of wearing heavy-weighted vests. However, if we get into proper position and strengthen the muscles helping support to maintain this proper neck, scapular, and posterior chain position, we can build a lead-proof body that is stable and fatigue resistant. So if you have any more questions, I think we have time, maybe a little more time for some questioning. You can also contact me at this email address below. One last thing I wanted to comment on is just the post-case deload and realignment exercises, which is crucial. After every single case, do some neck tucks, some cervical rotations, tilts, chest stretches, some hip stretches, and what's called a cat-cow, some flexions of the lower back, back and forth, to really loosen and bring yourself back to alignment to deload the body. Apologize if I went over time.
Thank you, Dr. Wright and Dr. Lee Choi. That was excellent. I learned quite a bit, and I appreciate you taking the time to set this up. In the interest of time, we'll move on to the panel, but I wanted to also let everybody know that the transcription of this, the video of this webinar will be available on the site, and we will also make available the slides with the permission from Drs. Lee Choi and Dr. Wright on the My SCAI website. So moving on to the panel discussion, it'll be moderated by Dr. DuPont. And if you have any questions, please feel free to address them on the chat box. And whatever questions we don't get to, we will also post the responses on the MySky website.
I know we're going to go over, so we'll probably try to keep this a little bit short. But I did want to give Islam a chance to touch on the toolkit that he is leading. I think it's important that our SCAI members know about this, and I think we'll talk about it more at scientific sessions. But can you tell us briefly about the toolkit that's coming out?
Of course, in less than a minute, or maybe two. So it's primarily actually led by the QI committee. They did a yeoman's job of getting this put together. And Dr. Arnold Cito, was also in the lead of it. A group of us have been supporting it, including Dr. DuPont. We have a group of slides that essentially, it's a very large number of slides. And the idea is that you have this toolkit where you take whatever slides you need for the SCAI membership. It'll be made available. And you present that to the needed party. So for example, if you needed to convince your radiation safety officer why you need this advanced equipment or better tools like the Rampart or the Protego, what have you, Nestec, then that's the group of slides that explains that. If you need to go to your administration and explain to them that the finances actually do make sense, and that it's not a zero-sum game, and they will benefit, the hospital, the institution would benefit. There's slides for that. If you also need to talk to your team about training, there's slides for that, regulatory aspects, compliance, and so on. So there's it's split up into different parts. We actually even added a couple of slides for the international group. Please watch for it. It will become available, I think, sometime in the next week or two, a couple of weeks, definitely before the meeting, the yearly meeting.
There's a lot of work being done by SCAI on regarding getting this equipment to be more mainstream so that everybody has a chance to use it. I mean, it seems like the minority of cath labs in our country have access to these newer devices that protect you not only from orthopedic injury, being able to get out of lead, but also protect you more from radiation injury. I think there was one question that we did not address. I think it was for you, Catherine. Somebody asked why you chose to stay in the lab, and I think I know the answer to that. The same reason that I probably would have as well. But if you want to just answer that question.
Yeah, so I mean, I love doing cases. You know, I'm a busy private practice person. It was funny, I got pregnant in my 4th year of practice, and I think those of us kind of at the beginning of mid-career see like this, like kind of, it felt like I was like finally in this part of my career and getting like all the sort of cases that I wanted referred to me, and I was like, oh crap, now I'm pregnant. So I think it was a choice. I kind of wanted to continue to grow my career and do those cases, but also B, like this is how I earn my living, right? I'm a private practice interventionalist. I make money by doing RVUs and cases, and I don't think I could do kind of clinic or service to kind of make that up. So at the time I was 4 days a week in the lab, so that was that's my job. And
yeah. But it is a choice, and it sounds like there are a lot of options out there. You have supportive partners that can help you get through. Golda, you had the opportunity to stay out of the lab, and that's fantastic. Question about the so physical therapy, Christian. How much time do you think is reasonable? You know, we're all kind of short on time, right? We all try to get all of our exercise in. We want to do our exercise, whatever we choose to do. But as far as physical therapy goes, to help us increase the longevity of our careers, how much physical therapy on a routine basis do you think every one of us should be doing to avoid injury as much as possible?
Yeah, it's a great question. For a lot of these physical therapy exercises, some people treat it as like, oh, I'm doing physical therapy now as a temporary thing. It's like, it's kind of a maintenance thing. It's kind of like I need to be dedicated time on a weekly basis to do these exercises. So that's until you're out of the lab, really. So you just keep doing it. So initially, I would say especially if you're weak in some of these muscle groups, I would do it 3 times a week because the typical physical therapy prescription is 3 times a week. You know, have your set of exercises to really hammer on and really work because a lot of these muscles are good for. They can handle a large amount of load. They handle a high frequency, so they can adapt pretty quickly, and so you can get a lot of improvements in a quick amount of time. But then after that, once you feel like you've got some stability, some kind of strength in those various muscle groups, you can shorten that down to 2 times a week, if need be, maybe just once a week. But certainly a weekly thing. It's not a thing you should do it. Oh, I have my shoulders acting up. I'll do physical therapy for the next couple of weeks and then stop. It's like that's just a prescription for danger. It's a long-term maintenance thing.
Great. Well, that's really helpful. And I personally, until I had my own lumbar injury, didn't realize how important core strength is. And I thought I had a pretty strong core, but apparently not strong enough to avoid an injury like this. So incredibly helpful exercises that you shared. So thank you for that. Are there any other questions from the rest of the panelists? Open it up for any other questions or speakers, because we are over almost 10 minutes.
I do have one question, and it's actually the same question we asked in the survey. For the panelists in general, what do you think is the biggest barrier to using the enhanced radiation and orthopedic protection equipment like Protego and so on? Now, we've asked that question in the survey, but I'm always curious for people that I personally know what their impression is. It's a little different when you work for the federal government because finances take on a different shape.
I can speak first to that, and I think probably in my mind the biggest one is probably the cost. But I know that, and you can probably speak to this, Islam, but that there is a little bit of a learning curve to learning how to use these devices, and in some places that is a bit of a barrier. I know some local places, some local hospitals actually that don't use it as much as perhaps they should, because it tends to add time to the procedure. But those are the two that come to mind for me.
I think same for us. As we've kind of alluded to, we actually have the egg nest in 2 of our 5 labs, and it meant shutting down the lab to install everything and redo the whole room. That's about 3 to 4 months that it took to do that. So that one at a time, the lab was out of commission. I think this is a short-term pain for long-term investment, but it still takes a little bit of canoodling with the administration to kind of relay that yes, it's down for 3 months, but in the long run, it actually makes sense. So I guess being able to be diplomatic about it and having the right people on your side might help butter the rolls a little bit. But I found that was a big hindrance on our end.
I can actually say that we've run the numbers in terms of the expense part, and Dr. Tawan's 100% correct. This is actually what keeps coming up as the biggest issue. Based on cath lab operations on a busy private lab, let's say typical 5 to 8 cases per day, not really excessive, or even 14, 15. Typical operating costs of somewhere between $20 and $30 a minute. You probably can pay for the most expensive of these technologies in 11 work days. So it really, when you put it in that perspective, that issue is something that we in cardiology really need to hammer home. The other aspect is the workflow. Yes, it does take the team time to learn how to get through it, but there is a lot of support, and part of the toolkit will discuss where to get that kind of support of training your team, and it's all going to be from the industry. You're giving them money to basically sell you a product, but part of the product is training. So if there are no other questions, I very much appreciate everybody's participation. I'm really flattered to have every member here as a colleague and a friend. And thank you to everybody, Dr. Patel. Appreciate your support in doing this. And I think if there are any other questions, we will try to address them into my SCAI. A copy of this webinar will be available for download and viewing. And if there's anything else, Kristen?
No, that's all. Thank you all so much for great presentations and discussion.
Appreciate it. And I look forward to seeing Jed in the cath lab sometime in about, what, 30 years? Some give or take.
Give or take. He'll start with the baby J.
Thank you to all the panelists for an amazing conversation. We really appreciate your time, and thank you to everyone else who joined.
Thank you.